Nice to see you. Nice to see all of you.
It's a pleasure to have you, sir. And so nice of you to make it this late. I know you told me that you sleep early, but thank you for waiting up and giving this talk, and the discussion follows. Yeah.
If you permit me, you can have some discussions after my talk, if permits, and then
because we are back to back, Dr. Ken Cusi will immediately join. We'll be taking off, and then we thought we'll have a combined discussion.
Okay, I'll maybe ask recuse. I'll give my talk and then be with you as long as I can. I'll enjoy Ken's talk as well.
Sure.
To see
So I think, should we go ahead? I think it's time to start. Let's start off.
Yeah.
You know, Dr. Yagnik is there. Dr. Nitin Kapoor.
Hello, sir.
Yeah, Nitin.
Good evening, sir.
Thanks. Good evening.
And Nita is there and Shilpa is there. They're all part of the team.
Good evening, sir.
Good evening. Yeah.
Nitin, will you introduce sir, and then, we could kickstart the meeting.
Right. A very good evening, but also good afternoon and good morning to everyone who's logged in for our IDEC Cafe meeting today from across the world. I believe we have over 4,000 listeners logged in right now, listening to us, and the number is increasing every minute as we talk. And it's our proud privilege to have with us today Professor Shiv Sarin, who probably needs no introduction globally. If I may say, he's the father of Indian hepatology. Sir is a senior professor and director at the Institute of Liver and Biliary Sciences based at New Delhi, clinician par excellence, a gastroenterologist, hepatologist, and a pioneer for clinical innovations across several fields and facets of hepatology. So is credited globally to give a huge number of relevant and new protocols for the management of patients with hepatitis and cirrhosis of liver and its complications. It's been part and the key leader for over 17 major treatment guidelines, including spearheading 5 major Asia-Pacific treatment guidelines in liver diseases, which are widely quoted, practiced, and all of us have used them. Professor Sarin has shown leadership roles as the president of the Indian Society of Gastroenterology, the Indian Association of Study of the Liver, Asia-Pacific Association of Liver, Vice President of the International Association of Surgeons, Gastroenterologists, and Oncologists, and now chairing the steering committee of EPAS. Sir has brought Indian hepatology to the global map, and heard several lectures before, but it's really a proud privilege for us from IDEC team to have Sir today. And we look forward to listening to you, sir, on a very interesting topic, a field that's so rapidly evolving, NAFLD, what we have to use in our clinical practice. So thank you, sir, for accepting the invitation, and over to you for your lecture.
Yeah, thank you, Nitin, and thank you, Sanjay, and all the listeners across the world. It's an enjoyable topic and very hot. I thought I will share with you how the names were selected. Bringing greetings from the Institute of Liver and Biliary Sciences, New Delhi, which is deemed to be liver university, the only liver university globally. What is there in a name? NAFLD, MAFLD, MASLD, and how do we define them? So the journey so far is starting way back from 1845 when Thomas Edison said fatty liver, and getting the term of NAFLD or NASH in as early as 1880. And then you have the journey going on where you have terms like metabolic dysfunctions, you have metabolic fatty liver coming in, and in 2020, MAFLD, and finally MASLD. Let me briefly give you what is NAFLD as far as broad definitions are concerned. It is more than 5%, probably more than 10% of the liver weight being fat, steatosis in biopsy specimens. If there is just fatty infiltration with no or minimal inflammation and fibrosis, it is pure NAFL, non-alcoholic fatty liver. When there is steatosis with inflammation, ballooning, and or fibrosis, then it is NASH. And The primary NAFLD is when you have no other cause except features of metabolic syndrome. Secondary, you have causes, and presumed NAFLD is when you have abnormal liver enzymes, no viral markers being present, no other common liver disease, but you have a bright ecogenic liver. And this very often occurs in lean people where you require to see for fatty acid oxidation defects, or you have EPLA or some other disease processes. Now, when the NAFLD came, people realized that nearly half the world drinks. 2007, 48% Australians, 2017, 63%. And Americans are never to be left behind. They score at 66% of the people. They would have 4 drinks or so. And therefore, the concept that you will have half the population excluded when you use NAFLD. Now, this Korean study showed that even light drinking, which is up to 9 grams, and moderate is 10 to 30 for men and 10 to 20 for women. Such people, when they were followed for about 4.9 years, those who were light drinkers compared to non-drinkers had higher FIB4, moderate drinkers had much more. And this led to the concept that fibrosis and of course other scores also worsen. So alcohol does impact the natural history of fatty liver. So this simple diagram came at that time. This is current means before 2019. People were separating NAFLD and alcoholic liver disease. And the new term MAFLD, which came, included some of alcohol, and the metabolic dysfunctions were included. And pure NAFLD, where no cause, no metabolic dysfunction, they were excluded. And they said that hepatic fat is correlating with lipotoxicity. So then the concept came of MAFLD. But remember, in 2005 also, as early as that people said that the new name should incorporate either metabolic or insulin resistance. So from NAFLD, a change was considered to be useful to give stress on insulin resistance or metabolic dysfunction. So a consensus was made where several of us were part, and this 21 members from different countries of the consensus panel, of many of them are now the frontline players of changing to MASLD, gave a unanimous consensus that we should include MAFLD rather than NAFLD in our dictionary. Now, what was the basic difference? Steatosis with no secondary cause, NAFLD. Steatosis with type 2 diabetes, with metabolic risk abnormalities with normal weight, or overweight and obese, this is MAFLD. So what are the metabolic risk abnormalities? I will come to it, but I want to stress that it is 2 out of 7, not 1 out of 7. Remember this, please. So now it's hepatic steatosis, and remember how the MAFLD takes, you can have imaging, ultrasound, CT, MR, or whichever, or fibro, and you have blood markers or scores or liver histology. Now, simple enough, every diabetic has fatty liver. Every overweight or obese has fatty liver. This may not be, this may be a little overstatement, but simple. Overweight or obese, you have fat. Diabetic, you have fat. Now it is the group with a BMI of less than 23 that you have 2 metabolic risk abnormalities: waist, blood pressure, TG, HDL, pre-diabetes, and homeostasis model, HOMA, or plasma HSCRP. When you use this definition, then people compare MAFLD to NAFLD. This is about 5,000 patients, and they found that MAFLD only, mere MAFLD, has an increased cardiovascular mortality. Again, another study shows MAFLD has increased overall cardiovascular, non-fatal or fatal events. Again, it shows similar data. This large Chinese data shows that those subjects who had a MAFLD or has NAFLD compared to control or metabolic plus NAFLD, you will see that the mortality was higher. Cardiovascular mortality was neoplasms and diabetes were higher with MAFLD. So what does it include? Metabolic factors, diabetes, overweight, or lean or normal with 2 other factors. And this very recent data from Netherlands, where subjects, 12,000 odd subjects, were followed for 23 years. And they said that MAFLD without alcohol has an 18% higher risk, and with alcohol, about 45% higher risk. So alone, MAFLD compared to absence of MAFLD adds, and of course, alcohol does add to the risk. Then why do you change when things are clear? Because non-alcoholic does not mean what it is. It is not alcohol, but what it is. It did not capture etiology of the disease. Unfortunately, the new term also does not include. For many, both non-alcoholic and fatty were stigmatizing. You call fat, it is okay, but you call somebody fatty, it may be stigmatizing. But the same may be true if you call somebody obese. Overlapping biological processes are there for both NAFLD and ALD. So the whole field, of course, is confused, but now maybe we are a little more confused. So this is what has happened. A multi-society Delphi consensus, which is I was part of in the initial first round and then I walked out, included people of choice by ASLD and EASL, and they made a committee, and there was only one person from Apostle, that's me, and then there was highly represented by the Americans and the Europeans, and several surveys were done. I'll not go into the process. First thing was we need to change, and the reason for need to change was the non-alcoholic and fatty words were stigmatizing. 2, we must have an overarching term. All, liver pathologists would say anything which is fat should be under a term called steatotic liver disease, SLD. Now, since there has to be a pathogenic or pathobiology behind, so they included a term metabolic. But I'll show you what were the different terms in this. And the final acronym was to be considered as MASLD. We'll come to it in a minute. How the name was chosen? To remove the stigma. The round 2 included fatty liver disease, steatotic liver disease, lipogenic liver disease, and the numbers were 46%, 48% of the people voted for it. FLD is as good as SLD. In the round 4, they said that add the word metabolic. See, there is no science behind this, is only way of giving your opinions. And then, since there was no clarity, expert committee was made, and they said change from NAFLD to MASLD, and NASH to MASH, and add a term called metabolic alcohol-associated liver disease. In this, you will see that the amount of alcohol considered as heavy is very high. So now, imaging or biopsy remains a must The overarching term given was steatotic liver disease. Now, steatosis is defined by imaging or biopsy, but not blood markers. Does the patient meet any of the cardiometabolic criteria? Yes, it meets the cardiometabolic criteria only one, not two. Suppose he meets one criteria out of 7. Are there any other causes of steatosis? If yes, if no, then it is MASL. Are there any other causes of steatosis? Yes, then it goes to specific. Otherwise, it is cryptogenic SLD. So the problem now is there are 4 types of SLD broadly. What MAFLD was defining this, maybe to some extent this, but mainly this. But now you have 4 variations. And these are the criteria for the adults where TG or A1C can be helped, and there are separate criteria for pediatrics. But remember, SLD requires imaging or biopsy. So now you have SLD, the term proposed. It means there has to be steatosis. And the term is metabolic dysfunction associated. And it could be, instead of fatty, steatotic word has been added. MAFLD changed to MASLD. Now, if there is an increased alcohol, what is increased? We are not clear. In MASLD dominant, you will have up to 140 to 200 grams of alcohol or 20 to 30 grams of alcohol easily. But it can range, as you can see, ALD dominant is 50 to 60 grams per day. So it means there is a gray zone here. Now, separately, there is an ALD. You have specific etiology, dilly, monogenic, miscellaneous, and cryptogenic. I'll not tire you out with this, but I'm telling you the field has become more gray than ever. So now let's say whatever is the name, how do you test it for people? Now here, 100, 500, 1,000 specialists sit and give you a name. And Ken Cusi was part of it. He was very much insisting, if Ken is listening, on that we should include insulin resistance somewhere, but somehow it was not part of the terminology. But let's say, what are the 5 P's? In my mind, this is only my own way of saying, who are the players? Patients, physicians, pharma, politicians or policymakers, and the general public. Let's see, if you change the name, how does it impact each of them? So the desire for a name change was mainly for a stigma, that it caused non-alcoholic, 61% said it causes a stigma. Fatty, 66% said it causes a stigma. In pediatrics, 60% said children fatty will be stigmatizing. But actual patients or patients' representatives were 9% of the total. Rest all were doctors. They were not asked. So the decision to change from MAFLD or NAFLD to MASLD was for 9% of those representing. Now the major problem to me, and I want your opinion, everyone listening, how will you detect MASLD? Tell a patient you need liver biopsy or you need an imaging, but who? Suppose you have a diabetic, you will say you are diabetic, you require this. It's okay. You are obese, you have fat in the liver. But for MASLD, now who will understand is steatotic? We ran a small, kind of talk survey and asked a couple of our outpatients and a couple of our endoscopy nurses. Well, 3-4 of them knew, but many of them would not understand what is steatotic fat. Everyone understands. Next, for the patient's perspective, will my treatment change from being called as NAFLD, MAFLD, or MASLD? So, are we justified in making a change just for removing stigma is my point P1. Now, from patient's perspective, the world over people say, yeah, 1 in 3, 1 in 4 have fat in the liver. But how will you say you have steatosis? The population included in the MAFLD were very easy: obese, diabetic, metabolic syndrome. But in MASLD, whom will you include? And the patients were motivated. They knew the risk. They know the risk of obesity. They know the risk of having diabetes. So if every diabetic is said, look, you have probably fat in the liver, go and get tested. But if you tell him you have steatotic liver disease, maybe he'll say, oh, I don't know which place to go. Now, from physician's perspective, steatosis is to be assessed by imaging or biopsy, not by blood test or scores. Now, alcohol, NAFLD excludes by and large, and the same is MAFLD, it excludes anything above 20 grams. Actually, NAFLD might exclude any alcohol, but moreover, NAFLD and MAFLD will go up to 20 to 30 grams. While MASLD will include for men up to 60 grams and for women 50 grams per day. Above that will be a separate ALD, and that's where the problems will be there. Further, the challenges are the key metabolic dysfunction in MASLD is insulin resistant, but the selected metabolic risk factors do not equally predict, like diastolic BP, HDLC, they're weakly associated with IR. So they have changed from 7 to 5. Also, only one cardiometabolic risk factor is included, not 2, which was integral to MAFLD. So I'm a bit worried we may overdiagnose the CMRs than they are present. The third part is the disease definition for a primary care, a village doctor or a rural doctor. Will he understand that what is SLD? He understands fatty liver, but will he understand, will the secondary care guy change his approach? I think time will only tell us. Now, the third player is pharma. The pharma has clear NAFLD, at least NASH CRNs, the scores. And the drugs were being developed. Now, if you change to MASLD, well, will it impact? Yes, probably. Ongoing trials might be, endpoints might change. Now, in MASLD, steatotic liver disease is there. So your endpoint has to be reversal of steatosis. It's not reversal of fibrosis. So how will you include that fibrosis part into your definition is a challenge. Well, whether the new terminology, diagnostic biomarkers will be a challenge, yes, I think so, because for MASLD, you might just need one, and you will develop scores based on that. MAFLD requires 2 biomarkers, and or diabetes and overweight and obesity. Well, I will show this slide later, NAFLD and MASLD definition. I'll show it in a minute, just published this month. The last 2 players for us are policymakers. Now, policymakers, let's say you go to a politician anywhere in the world and you tell him, oh, fatty liver is common. He will say, yeah, I know it. I also have it. You go and tell half of the people, maybe in the higher positions, will have diabetes or obesity. They understand that they are suffering or their relatives are suffering, and the public also understand. But to say steatotic liver disease may be difficult. So what is there if you change? Except for a stigma for fatty, I think MAFLD or even to some extent NAFLD was good. You have removed non-alcoholic in MAFLD, good, keeps alcohol levels low. And already 1,000 papers and several guidelines have come out. We'll see what MASLD brings for us, but I find a little advantage, rather more disadvantages with this term. I'll come back to this, for politicians and public policy makers. Overweight, fatty liver disease. Diabetics, hair, and lean or normal with any of these 7 will probably be very helpful for us. Now, this study published in August, let's say we use NAFLD out of 1,025% fulfilled. You use MASLD 26% fulfilled, MAFLD 25% fulfilled. So what difference does it make? They probably will give you same. I would therefore feel that hepatic steatosis or fatty liver in simple common man's is a good term and should be used. Maybe FLD alone. Well, jury is out. Many unanswered questions. Does MAFLD or do MAFLD phenotypes convey higher risk of liver-related complications and mortality? That itself has not been answered adequately, but very recently a guideline in press I have seen, this has come from Asia. It says that MAFLD different phenotypes, even the normal weight or low weight have high risk of liver-related liver disease. Well, HCC is very progressive. I hope I can show you something. Which phenotype responds best? Well, obese with weight loss and maybe 10% or so, and normal weight maybe 3 to 5%. Of course, everyone helps with lifestyle changes. Drugs are coming up. And new term, the overarching term steatotic liver disease will have to stand for test of time. Now, bringing down, what does surplus fat do? This is my perspective as a liver guy, but maybe you diabetes guys can do better than what I think. Inflammation means high ALT, or in other words, high ALT means inflammation across body, liver and extrahepatic. So fatty liver is more than 10% of fat in the liver. So all these steatotic liver cells do not have a healthy perspective. Body's innate immunity will try to remove. So there is hepatitis, there is healing, there is cirrhosis, and maybe liver cancer. So today, the NAFLD or MAFLD is the commonest cause of liver cancer. Those countries where HCC attributable to NAFLD is more than 35 or to 40%, India scores there. And this is the data we published from the WHO Collaborative Center at ILBS, that today if you take 100 patients with liver cancer, 39 have diabetes. So therefore, my joining you has a special purpose. We need to work to prevent every single diabetic not to have liver cancer. The second part of this is that since the hepatocytes have so much fat, there is inability of insulin to work well, and therefore there is insulin resistance. And this leads to more insulin production. And in simple terms, diabetes could be a result, at least in adults, of insulin resistance due to fatty liver. And this steatosis leads to a state where there is an extra lipid in the blood. You have high cholesterol or TG. So if somebody has gone out and got his cholesterol or TG done, oh, his cholesterol is high, he will take a pill, but will not ask from where the fat has come. And that probably is the result of fatty liver. So everybody with dyslipidemia should also be screened for this fatty liver. And this goes and deposits onto your arteries to give you hypertension, heart disease, stroke, or gallbladder stones. So I think the term metabolic dysfunction associated fatty liver disease, or MAFLD, fulfills well our needs for a combined cohesive approach. It's a hepatometabolic syndrome. Few years we showed that ago that if somebody has himself or has a family history of metabolic trait, then the liver disease due to alcohol is early, younger, with small amount of alcohol, and it is a more severe alcoholic cirrhosis in them. So remember, today we are seeing like ILBS, we have almost 47% admissions are due to alcoholic liver disease, and many of them are below the age of 30. With these initiatives and knowledge, the Government of India included the NAFLD into NCD program for screening. And India became the first country in the world. And now many countries are following this into their program. So now, whether it is for diabetes or for hypertension, like the 75-25 initiative, that 75% of the hypertensives by 2025 will be covered, includes now screening for fatty liver. And this is the beauty of that simple approach of NAFLD, starting from the periphery, community level worker, primary health center, community health center, and district level, identifying NCDs from bottom, and fatty liver is core to most of them. So now to all of you, and the reason for making it simple, is my liver healthy or on fire and inflamed? Well, you have to choose whether you want to use NAFLD, MAFLD, or MASLD. But for yourself, determine whether am I having fatty liver disease. So if there is family history, or you are suffering from metabolic syndrome, diabetes, blood pressure, heart or kidney disease, liver disease, gallstone cancers, obesity, snoring, or have polycystic ovary, well, you have fatty liver. If you are overweight, height minus 100 normal, and if 170 is the height, then your weight should be 70. But if you have any of this, then it should be height minus 105. A 170 centimeter guy should weigh 65. A simple abdominal ultrasound, an ALT, lipids, and sugar. So why I'm showing you this is this can be done at the primary health center by ASHA worker or a district level equally well, or by yourself. With this, I'll try and say, well, where there is a will, there is a way. I'm showing you this slide particularly for two reasons. One is to say who is the most important person. The most important person is the lady in the house. We have to educate her. We have to see that the children do not have this sponge. And lastly, we do not need a very sophisticated definition or a sophisticated tool to diagnose fatty liver. We just need to hit the right spot, the right population at the right time to make India healthy. A healthy liver will keep the country healthy. Thank you for your kind attention.
Thank you so much, sir, for that extremely elegant talk. And as always, it's such a treat to listen from you. I invite Dr. Sanjay to share his comments before we go on to the next.
So thank you very much, sir. I don't know whether I'm more clear or more confused. So I think we'll have more discussions ahead to clarify. But I think it's now encompassing a more broader definition from what we actually recognize NAFLD as before, bringing in the metabolic factors. And I think the last couple of slides made it very simple for everybody to see how we can sort of, bring up this diagnosis more easily, recognizing all the metabolic factors. So I request you to stay on the line, stay on the platform. We'll have Dr. Ken Cusi's lecture, and then we would love to have a very active discussion on both the topics. So let me introduce Ken to you. Ken is a very close friend, and he's been part of IDEC a number of times before. And I think he's got an incredible amount of work in this entire area. Just to introduce him to those who don't know him, he's a professor of medicine at the Division of Endocrinology, Diabetes and Metabolism in the Department of Medicine at the University of Florida. He received his medical degree in Argentina from the University of Buenos Aires School of Medicine, and is board certified in both internal medicine and endocrinology, diabetes and metabolism. Prior to joining the University of Florida, Dr. Cusi was a faculty for over 15 years at the Diabetes Division, University of Texas Health Science Center at San Antonio, and the Veterans Health Administration System in Texas, one of the leading diabetes programs in the country. And he's a principal investigator in the ongoing NIH grants, investigator initiated as well as multi-center industry-sponsored studies with a focus on obesity, type 2 diabetes, and non-alcoholic fatty liver disease. We're privileged to have him today speaking about what has changed in the management and the ADA 2023 guidelines. So over to you, Ken, and we really look forward to hear a very interesting talk from you.
Thank you, Sanjay, for this kind invitation. It's always an honor to share this platform with so many friends from India. And we heard such a wonderful presentation that summarized all the challenges that go in the name. So that process was a two-year-long process. So again, we hope we focus on the patients more than anything else. So I'm sure I agree with many of the points made by our prior speaker. So with that, these are my disclosures largely for biomarkers of drugs that are in development in the NASH field. And with this, we're going to dive in right away. And we have 30 minutes, is that correct? To cover 3 questions. Number one, if we understand why the rate of NASH is so high in obesity and diabetes, it will help the management of our patients. So I want to go with that background, then dive into the major guidelines. I'm just going to touch briefly on the controversy from an endocrinologist perspective. I was part of the nomenclature, and we'll get there, but I want to highlight more the ADA because I want to focus on the patients. Don't, as we say in the United States, don't take the eye off the ball. The ball is the game of, I love soccer. For me, my goal is to help people, and that's why I'm going to emphasize more what we can do to help them. And the ADA in June came up with new guidelines. And then management. So how do we going to put these teams together, the primary care, diabetologist, hepatologist? I would encourage you to start treating today. In India, you have already saroglitazar. You also have pioglitazone. I'll tell you, probably the most misunderstood drug in the diabetes field. And again, all about GLP-1s. And just briefly about the future. So this is where I live, near Orlando, down here. If you come to visit Mickey Mouse, come and see me. I would love to have you at our place that looks something like this. I worked many years in the VA administration hospital, and this is our main university hospital with about 1,100 beds. One slide about epidemiology. This audience doesn't need to know much more, but I wanted to share what was shown so elegantly in the prior lecture, that as you increase the rate of diabetes in darker red, you also increase the rate of non-alcoholic fatty liver disease or steatotic liver disease. But the most important thing is to remember that up to 1 in 5 people with type 2 diabetes already has significant fibrosis, F2 to F4. India is no exception. I think the color is about the same as in the United States. And it is a big major problem. So we want to identify who are those who are heading to cirrhosis. Now, the question is why obesity and type 2 diabetes? A simple answer, we're not absolutely sure, but I'll share some important concepts that also had to do with the nomenclature debate that we talked about. The first thing to understand is that it is very important to understand what is the role of metabolic risk factors. So what we are looking for with metabolic dysfunction is really insulin resistance. Now, there are a number of concepts. So let's start from the bottom, and this is a schematic representation to get some concepts across. Number one, you can be obese and metabolically healthy. It's a minority, 5–10% of patients, particularly if they do regular exercise, can be insulin sensitive. It is rare. Most of our people in our clinics are not metabolically healthy. But you can have metabolic dysfunction, dysfunctional adipose tissue without any metabolic feature that's obvious, as you see up here, with prediabetes, hypertension, dyslipidemia. So this is an important concept because there are some people, that's why I would have preferred to keep steatosis as steatosis, as we had it, without having to add necessarily metabolic risk factors. We have done hundreds of studies with insulin clamps, which is the gold standard. For example, in young adults that have one or two parents with type 2 diabetes, as I know is very common in India. Our lab director is from India. I've worked with many very young, wonderful and talented people from India. They almost all have a parent with type 2 diabetes. Unfortunately, I'm Hispanic. The same is happening in Latin America. And in young adults, they may not have any feature in metabolic syndrome, but when we screen them, they can have steatosis. So that's why it is difficult to say that you'll have steatosis is only meaningful if you have a metabolic risk factor. But what you and me see in liver clinics, in endocrine clinics, is above here. I would say that in endocrinology and diabetes and hepatology clinics, we see only this. That is why I feel a pathologist cannot conceive insulin resistance in the absence of metabolic risk factors. But it happens. But as you get more metabolic risk factors, of course, you'll have worse insulin resistance, longer duration of hyperglycemia or diabetes, and more likely to have fibrosis. So many studies have shown that if you have more of these risk factors and more severe obesity, you'll have more NASH, more fibrosis, and I agree with that. The real problem is that primary care is more here. We have to find a definition that helps everybody, not only endocrinologists or hepatologists in the clinic, but also primary care that are going to find themselves having a lot of cryptogenic cirrhosis because they may have steatosis without very obvious metabolic risk factors. So keep that in mind. This is another way of looking at the same problem, and it is really important. It looks complicated, but it's fairly simple. And this has been drawn in many iterations. This one we did with Dr. Gastaldelli. So if you go now from people with normal glucose tolerance, healthy individual, you do a glucose tolerance test, completely normal, and without fatty liver, their glucose is going to be below 100, I would say below 90. They're going to be very insulin sensitive. Forget about the green line of insulin clearance, and they're going to make very little insulin because with a small amount of insulin, they uptake foods and metabolize glucose very efficiently. You do an oral glucose tolerance test, a 2-hour test is going to be near 100. Now, as you go along this line, you're going to have people without diabetes that are lean that may have steatosis. Some may not have any of the 5 typical metabolic risk factors, but they're insulin resistance. Many people have published this. We have done lots of euglycemic insulin clamps in San Antonio, finding the individuals like this that have completely normal glucose tolerance. They have no feature, no cardiometabolic risk factor, they're very insulin resistant. They typically have a parent or two with type 2 diabetes. They keep the glucose normal, insulin sensitivity is coming down. They keep things normal because they double or triple their insulin secretion. Now, over time, if you add obesity to the equation, now you begin creating insulin resistance if you didn't have it, or you worsen your genetic predisposition. Now glucose begins escaping. You begin having slightly higher glucose, might get above 100. You might have your 2-hour glucose not being near 100, but in the 120s, 130s, or then hitting the 140s in the impaired glucose tolerance range. And as you move on, we don't know why, beta cells over time reach a max in those who have a genetic predisposition. Thanks God, most people with obesity and insulin resistance can make enough insulin to not have diabetes. But if you have a gene that we don't know what it is or genes, then it comes down and now you have type 2 diabetes and worse type 2 diabetes. So this is the spectrum that we're dealing when we talk about NAFLD. And I'll tell you, as you can imagine, people who have hyperglycemia plus severe insulin resistance are the ones who are going to have more fibrosis. So that's my little a token of appreciation to the metabolism of fatty liver and diabetes. And we just published a paper. These are this paper is unique. I never had a paper with so many authors from our single center, but these are all the primary care doctors that helped us, endocrinologists, hepatologists. And what we looked at is, of course, if you compare people with fibrosis compared to those without fibrosis, and again, I just highlighted some, of course, they'll have higher BMI, higher blood pressure, lower HDL, high triglycerides, higher liver enzymes, all the expected things, lower adiponectin, lower, and they're going to have something that we call a fatty acids that are not that different. But when you look at the insulin, this is done at the expense of an insulin level that's much higher. So to take into account this relationship between your fatty acid levels and your insulin, we have developed an index called the fatty adipocyte insulin resistance index. Now, one thing I want to highlight is that glycemic control, I don't say it's not important, but seems to be less of a factor for unclear reasons. Now, when you look at the adipo-IR index, just think about it like a HOMA for adipose tissue. HOMA is fasting glucose, which is a good indicator of your hepatic glucose production, times the insulin. So if you have two people with a fasting glucose of 100, but one needs an insulin 3 times higher, that person is going to be very insulin resistant. And that's what we basically, the HOMA measures. The same concept I want you to learn about for fat, because you can have two people with the same BMI, both being obese. Some can be metabolically healthy, meaning there's fatty acids, free fatty acids in blood are low. And remember, the fatty acids are coming from your adipocyte that's breaking down the triglycerides. The triglyceride has 3 fatty acids that break down into fatty acids. So same as for the liver pouring out glucose, the fat pours out fatty acids. The problem is when that fatty acid goes out into the blood, it needs to find a different home, and it goes to the liver and it's toxic. So in obesity, as I like to tell my patients, what happens is you have like a toxic, it's like you had a chronic infusion of alcohol to your liver. Instead of being alcohol, it's fat, and that fat is toxic. So when you combine that with insulin, among all the factors that you could mention, the factor that accounted the most for fibrosis was how sick your fat is. And we have had this observation also for adiponectin. The lower your adiponectin, the worse your fibrosis is. This just highlights the link between fat and the liver. And that's when we talk about metabolic dysfunction, these cardiometabolic risk factors are not causing damage to the liver. They're just an expression of insulin resistance and how sick your fat is. So this is why it's so important to separate insulin resistance from cardiometabolic risk factors, but the correlation is not great. Okay, so with that, let's get now into the guidelines. Okay, so the one thing that made the American Diabetes Association change was that the guidelines before said just send them to do a ultrasound or an imaging or referral to a pathologist if the liver enzymes are elevated. Here we took 561 people just coming to the regular diabetes clinic, and we did a transient elastography test by FibroScan. In all of them, they had never heard the word fatty liver. They were not offended by it neither, but they didn't even hear it before. And we looked at 70% of them had steatosis and 21% had fibrosis. Liver enzymes were not helpful. More worrisome is among this 21%, 15% had F2 to F4. Again, liver enzymes were not good. This evidence, there's nice studies by Dr. Harrison, more recently the group of Dr. Lumba, many studies from India and other countries have shown this. So the key thing was to try to find something that could be more helpful for primary care doctors. I participated in this first effort for primary care and endocrinologists with a guideline that really was similar to what has been published worldwide in terms of using FIB4 first followed by a second test, most times elastography. But this, I agreed to only do it if we were going to do it in agreement with AASLD, and Dr. Vinela and Dr. Cusi helped extensively in this guideline with the three usual suspects: type 2 diabetes and obesity at the top, pre-diabetes next, obesity with cardiometabolic risk factors that I hope now you grasp a little bit better why, and then liver enzymes, but above 30, okay? When I say 30, all my peers here in the United States, endocrinologists and primary care, just roll their eyes. Well, hepatologists have known for a long time that in epidemiological studies, increase the rates of mortality and morbidity in large population studies when it's above overall, say, 30. So what we need to learn as endocrinologists, first is to risk stratify. And what I would encourage hepatologists is to be more aggressive in measuring an hemoglobin A1C in all your patients with NASH, and being very aggressive with statin therapy and obesity management. And my message is that I think as endocrinologists have to be more gastroendocrinologists, I think hepatologists and gastroenterologists have to be a little bit more endocrinologists and be brave to start prescribing medications, because what I see in the United States is a pathologist send to the endocrinologist, and the patient is lost in between. The endocrinologist may not start the therapy, and patients remain lingering and progressing to cirrhosis. So this audience knows very well. I just wanted to share what the guideline did is to do this FIB4 followed by liver stiffness measurement, or ELF as a better validated test, and putting them in these three buckets. So I'm going to move on as all of this is being published. I wanted just to bring to attention the great work of AASLD. I was a reviewer for this. We did a big effort to keep everything very aligned between guidelines, and to send them to hepatology for your additional imaging and eventual liver biopsy. So very, very good things. Now, the previous review was excellent. I have nothing much more to add, but except my little editorial about it. Dr. Roden, a good friend from Germany, we were the two lonely endocrinologists. Although there were other 8 or 10 endocrinologists that voted in different stages, there were 187 hepatologists. There were a few patients. But what I want to point is something that we agreed with Dr. Roden in terms of the good and bad. Number one, this was a difficult task. Trying to reach consensus in such a controversial issue is difficult. There's no great name for the disease as we understand it today. Just highlighting what has been said, steatotic liver disease, again, changing for Latin might be less stigmatizing. I hope so. I think where the greatest problem as an endocrinologist come from defining metabolic dysfunction. If you think about it, is very broad. Pediatricians link it to genetic diseases, endocrinologists to insulin resistance. And how to define that from a clinical perspective is, just think about it, it's a problem. We're trying to define a biological finding, steatosis, which is driven by complex glucose and lipid pathways, into a clinical phenotype in which insulin resistance is just one of the mechanisms that causes hypertension, one of the mechanisms that's implied in diabetes. But you don't get diabetes unless you have a genetic defect on insulin secretion. But we still are asking insulin resistance to equate itself to diabetes and steatosis to be justified because you have diabetes. So we're trying to match a biological finding in the liver with clinical features. That's going to be fraught with trouble. The Delphi 4 round was the one that shows metabolic, and then a small panel decided how to define that. Now, I just want to highlight a little bit what was said, that when after people felt that steatotic was probably NAFLD was not a great name, I think everybody agrees. These were the initial votes on metabolic. Only a third felt comfortable with that. However, as things evolved, people were asked to should we call it steatotic liver disease 1, 2, 3, 4? So NAFLD would be steatotic liver disease type 1 or something else. Of course, I think the majority wanted a name. And here where it gets dicey. So with roughly a third not a large majority, that choice was between metabolic or not. It could have been NAFLD or not, could have been lipotoxic liver disease, but I think it was a strong drive to include metabolic in the name. And that's how this simple majority evolved. And from there, you can see that there's a lot of fragmentation down here with no name reaching more than 30% of a third of the votes. Of course, if you add them, it would be more significant. And finally, down here is where I think we needed to talk a little bit more, because there were almost as many people as those who wanted to change or not the criteria. I was more inclined not to change the criteria for now, change the name, let things settle a little bit, and then this debate how we were going to define this. And but by a simple majority, 53%, the diagnostic criteria were changed. So looking at the positive of this, steatotic liver disease and the term MASLD remove stigma. Again, that is only true in the English language, but it's important. The disease now has a positive diagnosis with at least a cardiometabolic risk factor instead of a negative one. And then steatosis plus one cardiometabolic risk factor will often be a surrogate for insulin resistance, which is the driver of this metabolic dysfunction. On the caveat side, where we have to do some more additional work, is I think this needs a little bit more validation. I mean, among them, it's not the same as a mirror of insulin resistance to say you have hypertension or that you have obesity or type 2 diabetes, in which the chance of having insulin resistance are much higher. The other thing is that definitions have changed now. We had a steatotic liver as the diagnosis, and now it has to be with a cardiometabolic risk factor. And again, I think that, as was shown in the prior presentation as well, but may not match as well as we wished. It will match particularly in young adults that are seen in primary care. So I think primary care doctors are going to have a lot of problems calling somebody with steatosis, oh, you have cryptogenic steatotic liver disease. I think it's going to be complex. And I begged in the end that they really put that these people were most likely MASLD and maybe cryptogenic, and maybe then in these we would do some measures of insulin resistance. The problem is that HOMA is not easy to standardize even within a country or an institution. So all of these things have some caveat. And then a small proportion of people who are lean with steatohepatitis may not have very obvious cardiometabolic risk factors, although they might have more visceral fat. And then they only mentioned hyperglycemia. I had suggested that we call it type 2 diabetes, because you can have hyperglycemia from pancreatectomy. You're going to be insulin sensitive, but you may have steatosis because some degree of malabsorption, or you can have cystic fibrosis in which you're not insulin resistant, or type 1 diabetes. So hyperglycemia is a big bag of many things. Okay, in the last few minutes, I'm going to talk quickly about management and the guidelines. But this call of action led the ADA, who participated in that call of action, to do the two-step approach of FIB4 with transient elastography. So this is a predominantly hepatology audience, I understand, where FIB4 is the initial test has many problems, but it's cheap and doable. But it's trying to identify those with stage F2 and F4. We call clinically significant fibrosis, but these are the ones who are going to have obviously cirrhosis, hepatocellular carcinoma, which we had known for decades that people with type 2 diabetes had a threefold incidence of liver cancer. And NASH is now the link, and even cardiovascular disease. Second is if you have persistently elevated liver enzymes, there are other causes of liver disease, not only NASH. So talk to your hepatologist or do some other testings. Again, we talked about liver stiffness and ELF as the second test. And finally, hepatologists, I would say the other way around, diabetologists need to work closely with hepatologists and as a team sort things out. The other things to remember are that for people with prediabetes or diabetes, lifestyle changes are important. We don't want to be just giving GLP-1s without ideally a structured weight loss program, physical activity. But if you are overweight or obese, you need to use a GLP-1 or try to prescribe a GLP-1. And I encourage hepatologists to start using these medications, but hepatologists are using interferon, which is very difficult. I would never have dared to use that or have the expertise. So you did that, so you should start the GLP-1s. And if you have diabetes, pioglitazone or GLP-1s, and I'll show you a little bit the evidence for that. Another thing I wanted to add that people have overlooked is that in September last year, the ADA and the European Diabetes Society updated a little bit their guidelines, which you're very familiar with, SGLT2 inhibitors for heart failure, CKD, GLP-1s for weight loss. And they didn't include it in the table, but in the text, there are like 2 pages talking about fatty liver, which made me very happy, and recommending the use of pioglitazone or semaglutide. So with that, I have to say that one thing that's really important is once you have cirrhosis, probably insulin is your best choice. Although there's a small study that used semaglutide and safely, insulin is probably the safer choice. And here I review with Dr. Castera from Paris the different agents for people with liver disease. Once you have decompensated cirrhosis, insulin is the absolute drug. You could use most of them in early cirrhosis. I think hepatologists should begin working more with endocrinologists to use continuous glucose monitoring and other things to prevent hypoglycemia, which these patients are very prone to. And last but not least, their cardiovascular risk. Statin therapy is safe, even with mildly elevated liver enzymes. But you got to be careful in people with decompensated cirrhosis because obviously cardiovascular disease is not going to be the primary cause of death, but liver disease. Don't forget about metabolic surgery and use with caution in compensated cirrhosis and avoid in decompensated cirrhosis that's associated with increased morbidity and mortality. So with that, back to primary care, we need to manage cardiovascular disease. We need to manage liver disease. And why to use pioglitazone or not, it's very, very important that anything that helps you reduce weight or change the biology of fat is going to very much help your patients. So remember, I'm just going to stop here. These are your options today. There are future therapies down the road, such as, well, you are familiar with a dual agonist. The one that has been approved so far for diabetes is tirzepatide, that lowers liver fat quite significantly. And with that, I'm just going to stop here. Remember that there are therapies you can use today that will help your patients. So hopefully with lifestyle therapy, we will prevent people from developing cirrhosis. Thank you.
Thank you very much, Ken. And it was an excellent lecture. I think it brought out so many points. So I'm going to request Dr. Sarin also to join us, and Dr. Yagnik and Dr. Neeta Deshpande is also there with us. And would love to, pick your brains and do some question and answers and get out some replies. So I'm handing it over to Nitin. And Nitin, would you like to start the ball rolling?
Sure. And I think I have 2 burning questions, maybe to begin with Professor Sarin. So you did allude a bit to people who have a BMI of less than 23 and they can still have excessive fat and metabolic complications. So my question to you is that are these people with lean NAFLD or MAFLD, whatever we call it, are they equally aggressive like those who are obese, or how is their risk for cancer and mortality and cirrhosis?
This is a very important question, and we have our own data of about 779 liver biopsies published few years ago. Those with BMI of less than 23, BMI between 23 and 25, and BMI above 25, the fibrosis score and NASH score were about same. There was no difference between those with low BMI. Two, we have also published that people with lean NASH or normal weight NASH have HCC liver cancer, which is more aggressive. We do not understand, but I think there is a strong genetic basis. Maybe they have a bad adipose tissue, or maybe they have a different profile of the FTO genes or other visfatin and others. But nevertheless, the disease is present, and weight loss does not always help them. So we need to work more in this group of patients.
Thank you, sir. And that's a great insight. And I think Professor Yagnik is there with a large body of work in this area. And yes, this is important. So just one other question, and this is more of a clinical question. Many times we as physicians would say reports of fatty liver grade 1, 2, and 3. And now that the nomenclature has changed to MAFLD, and if at all to MASLD, that grading was based on echogenicity of what they find in the ultrasound. So is that also carried on? So are we going to expect reports like MAFLD grade 2 and MAFLD grade 3, or how is it going to be?
Well, I would say the simple things always last forever. Like sunset, sunrise. You may time it early or late, but they sunset and sunrise. So fatty liver will remain as fatty liver, in my opinion, and radiologists or other people will call it. I think it should stay grade 1, grade 2, grade 3 fatty liver on imaging. That should be there.
Great, sir. Thank you.
So Ken, let me ask you a question. With all the new nomenclatures that we've had, looking at the whole spectrum of different nomenclatures, does treatment options vary, or it's just a question of name, but the treatment remains the same, irrespective of what the nomenclature is?
Sanjay, you're younger than me, but maybe old enough to remember all the ink spent on metabolic syndrome between the year 2000 and 2010. Do we call it insulin resistance syndrome, metabolic syndrome? I warned the committee to try to avoid getting into 1 or 2, all these criteria, because we spent 10 years of diabetes meetings divided among criteria. In the end, there's still 5 definitions of the metabolic syndrome with different cutoffs. And I don't think that has helped patients in any other way than telling them that you have obesity with cardiometabolic risk factors. So it doesn't change anything in terms of your treatment, other than the separation if you're treating just obesity or you're treating diabetes. So I hope that whatever the field adopts, just focuses on early certification. I said, can we wait a year or 2 to change it? We just gave the diabetologist some recommendations. I've been trying 10 years to give them recommendations to do this. I got with ACE, which is a big group of endocrinologists. Finally, everybody's on the same boat, and now they moved the name, and there's a lot of confusion again. So bottom line, it doesn't change anything you do. Risk stratify and treat with what we have until they're FDA approved drugs.
Yeah, another quick question. Both of you did not allude to whether there is any difference between adolescent group and adult group. I mean, how much do you see in the adolescent group similar sort of separations happening? And this question is to both of you. Is this something that we don't talk about, or do we don't see it?
What do you mean, NASH in adolescents?
Yeah.
Oh, it's terrible. In the United States, I work with it. I mean, Dr. Sarin has more experience than me, but from my small experience here at UF, and at endocrine meetings, they're having a real hard time. And as you know, Sanjay, diabetes, type 2 diabetes in youngsters burns through medications, makes them fail very quickly. They're very aggressive. A quarter already have eye and kidney complications after a few years. It's going to be very, very bad, and they have a lot of NASH. I see people in their 20s already with advanced fibrosis. But Dr. Sarin, you have seen 10 times more adolescents than I have.
Yes, it's very common, Sanjay. It's a good question, and I think the genetic basis is true. The children born to patients, we see one patient has come for liver transplant, and then the donor, maybe 18, 20 year, also has fatty liver, maybe stage 3 fibrosis. So this is very common. And now, like we used to see for gallstones, the age from 40 came down to 30, and now you see gallstones as young as maybe 3 years to 5 years age. The same is going to happen, in my opinion, in the younger kids, that you will have a fatty liver, maybe more fibrosis, if there is a genetic or inheritance basis. Therefore, it is extremely important. And there was a beautiful diagram which was proposed by Aslam and Jacob George. They showed 3 types of phenotypes. And I want you to stress and think about it. The first phenotype is there is no parental or history, nobody in the family. You are the first generation who became obese or became diabetic. So the effect of environment in them will be very, very major. The genes have very little effect. Now you have the grandchild. In the grandchild, the effect of the genes is maximum. The environment has very little role. Lifestyle has very little role. So these are the lean, thin children or lean, thin adults of the third generation who will continue to have fatty liver disease. And if they have extra fat, young children, they will have much more aggressive and severe disease. So these 3 phenotypes will be there: first generation, second generation, third generation.
I think Dr. Yagnik has some, I think work in this area. So let me ask Dr. Yagnik to pitch in and give his opinion on this.
Okay, thank you. And thank you to 2 speakers. I mean, I learned so much. Some basic differences in thinking. You perhaps know I am known internationally as the thin fat Indian. So I coined that term and published my picture in Lancet in 2004. So John Yudkin and myself, who are there in the picture, we both had identical BMI of 21.2. John's body fat percent was 9%, and my body fat percent 25 years ago was 21%, more than twice as much as John. We call that YY paradox, Yajnik-Yudkin paradox. That was the adult picture. Then I got very close to David Barker and got into developmental origins and intrauterine programming. Both of you have spoken about the end-stage disease in adults. And I have now a cohort which we have followed for 30 years in 6 villages near Pune. We started in 1993 with mothers who were married but not pregnant. It was the first pre-conceptional birth cohort in India, and now the 3rd generation is born. The babies in the 1st generation, which is the 2nd generation, which is F1, they were 800 grams lighter than the English babies, 2.7 kg as opposed to 3.5 kg. But Indian babies had higher fat, measured either as subscapular skin fold, on whole body MRI, or cord blood leptin, and the Indian baby was thin fat. And we have related it to fetal undernutrition. If I try to remember my medical college days, the first description of fatty liver by Professor Ramlingaswamy and Dr. Gopalan was in Kwashiorkor and Marasmus. So fatty liver was very much a part of undernourished, childhood undernourishment. The animal model which was taught to me in my medical college was actually a methionine deficiency model. So one carbon metabolism is an integral part, and we have shown one carbon metabolic disturbance in the mother with higher homocysteine levels due to B12 deficiency as a strong determinant of adiposity in the child, not only at birth, but at 6 years and 18 years. So I actually come from an entirely different side of the story, undernutrition. Now, in the second half of my first round of measurements in utero, between 1993 and 96, I had the idea of measuring liver and kidney growth of the fetus in the uterus. So on 300 babies, we have liver growth and kidney growth in the third trimester. Now at 18 years, 30% of these thin children were pre-diabetic. And I looked at their liver growth in utero and subsequently, which we had measured by ultrasound. Slower liver growth in utero in the third trimester and larger liver size at 18 years without fatty liver stigmata was a strong risk factor for pre-diabetes. 2 out of 3 children who had lower liver growth but larger liver size at 18 years had pre-diabetes at 18 years of age, with an average BMI of 19. 2 out of 3 girls with pre-diabetes had a BMI below 18.5, and 1 out of 3 boys. So I think the current thinking has completely missed the intrauterine origins, which are predominantly nutritional and epigenetic. And we are concentrating on the end-stage liver disease in obese populations. So
Dr.
I have a
Janik, have
very different view of this.
I think Ken wants to make a statement.
Yes. Have you had a chance of measuring insulin resistance in these, like a HOMA or something? Because maybe there's also a genetic component in the Indian, with the Indian background of insulin resistance that even in lean people is driving this.
Yeah, so I described the thin, fat, insulin-resistant Indian 30 years ago. But that time, I trained in Oxford, so I trained with David Matthews. I'm one of the volunteers for the Sigma model. So I'm one of the model. I mean, I was very much there when the models were developed. What has come out is the pre-diabetes in young thin Indians is largely driven by insulin deficiency rather than insulin resistance. Lancet Regional Health may issue as my paper on genetics of subtypes of type 2 diabetes in Indians. And interesting thing is that of the 4 subtypes which we described with left group, the severely insulin deficient, severely insulin resistant, moderately obese, and mild, the largest percentages of severely insulin deficient diabetes in India. And interestingly, we calculated gene risk scores for 18 traits in diabetes, including liver lipids. And liver lipids are a strong association with severely insulin deficient diabetes, severely insulin resistant diabetes, moderately obese diabetes, but not with MARD. So I think it's a complex picture. World is influenced by American views on obesity. I have had debates with Ralph DeFronzo, and I think the picture is very different in other countries. And I think if we say that 80% of diabetic patients are in LMIC, we need a representation from these populations on NAFLD, role of early life undernutrition as the initiating event, which increases sensitivity to relative overnutrition in later life, role of one-carbon metabolism disturbance, and epigenetic programming of these metabolic diseases. So that's my take on this.
So, Ken, let me ask you a couple of questions that have come up from the audience. If you can, tell us your views on this. So, Dr. Zubair Ahmed wants to know: does obese diet in NASH NAFLD mice model, can it be protective against inflammation?
I saw that the obese diet and that. So the obese, I don't know exactly what the obese diet means. But again, what we do know that is pro-inflammatory are saturated fats, particularly palmitate, and coconut oil, and it's also fructose. I mean, fructose, which is so corn syrup and is so prevalent in Western diets. Those are the two things that when we give to mice, they develop NASH. So look at a couple of papers in which we gave trans fat, fructose, and a little bit of cholesterol, like the McDonald's diet. That's the perfect pro-inflammatory pathway. But there's no obesogenic diet that would really not cause steatosis or inflammation, I think. But I don't know if I answered what exactly the question was.
I think I wanted you to stress on the fact that fructose is very important, and we are recognizing fructose more and more as an incriminating agent. Okay.
Yes.
Another one that is nice one is: can rapid weight loss worsen liver function in NASH patients?
Good question. See, but don't be afraid to do it, because in the end, it turns out to be okay. And what we learned in bariatric surgery, there was this fear that because some people in the initial stages died of acute liver failure because they had advanced disease. What happens is when in bariatric surgery, you're in a liquid diet for days after the procedure, you are burning rapidly a lot of triglycerides as a source of energy. So you have a flood of fatty acids that acutely cause an elevation in liver enzymes. But later on, there is a normalization, and bariatric surgery reverses steatosis in 95% of the patients, inflammation in the vast majority, and even fibrosis. So no fear of rapid weight loss. But again, don't do it in people carefully, people with cirrhosis early and not in advanced cirrhosis, because unless you're in a tertiary center, I mean, you're going to have bad outcomes. And again, I know Dr. Sarin probably has also more experience than I, but in general, cirrhosis is a little bit too late to try that.
Another question I think I would ask Dr. Sarin this: how to deal with diabetes patients with biopsy-proven NASH? This comes from Miss Metro. Do you have any experience in this? I mean,
yes, it's a very common problem for us. In the 2019, we just looked at our records of 8 years, and we had close to 2,300 patients of cirrhosis and diabetes. But everyone was treating in our group differently, and we didn't have any standard protocols. But by and large, my own protocols and thought process is metformin to me is the best drug for cirrhosis, which is compensated, and diabetes, for following reasons. One, it helps in somewhat weight loss. Two, it is the best drug to prevent liver cancer. And third, which we presented in the American Liver Group, was it decreases portal pressure. So metformin was able to reduce the portal pressure from 2 to 6 millimeter in about 60% of the patients. So I think by being a drug which can kind of stimulate cell deactivation, it is one of the best drugs, and through AMP kinase pathway, it prevents liver cancers. So my first choice in a diabetic who is cirrhotic would be metformin. My second choice drug can be now maybe a GLP-1 or a DAPA kind of a combination. I generally would not like to use insulin unless it is a advanced disease. So this is how we manage most of our patients. Couple of trials are going on, but first choice is metformin.
So, Ken, let me tease your brain a little bit. So, if you had a pre-diabetic patient with, grade, ultrasonologically grade 2 or grade 3 fatty liver, would you think a combination of DAPA, GLP-1, and pioglitazone would have a zero conversion rate to diabetes?
Yeah.
So should we treat our pre-diabetes very aggressively? And
Well, you know Rao's long-term study very well, but he had a little bit of FibroScan data in a recent study that showed that it seemed that fibrosis doesn't progress. My personal experience, I put them on. I recommend the audience try 15 milligrams of pioglitazone. There are now many studies that show that the weight gain is 1%, maybe 2%. And these are randomized controlled trials against 30 and other doses. If you do a diet, you should gain no weight on 15 milligrams. And pioglitazone there are now 6 studies showing consistently reversal of steatohepatitis. So I start 15 milligrams, and I don't do it if they already have edema or they have heart failure, but it improves left ventricular function. Pioglitazone have shown to be the best drug to reverse the progression from prediabetes to diabetes by 70%. It reduces cardiovascular disease, and it's dirt cheap. It should be very cheap in India too. So try 15 milligrams. And again, if the patient tolerates well, which happens in 95%, you can bump it up to 30. We did studies with 45, but I think the benefits of 30 or 45 are equivalent. And then in a younger person, use 30. And I love the idea of combining with an SGLT2 inhibitor. There's going to be 5 or 8% who can develop edema, which would be prevented with the SGLT2 inhibitor. And there are studies published that you have net weight loss combining SGLT2 inhibitor with pio. I didn't show you that there's also a study called SUSTAIN-2 that added semaglutide to people on pio, and you had a weight loss of 6 to 8%. And normalization of A1C in 75% of the people. So I always try to use pio with an SGLT2 or GLP-1. And it's not one or the other. I mean, I have most of my patients are on pio 15 or 30 and a GLP-1, and they are losing weight. And if you just think about it, even if you use 30 milligrams, which the weight gain is 2, 3, 4% without a diet, these drugs are now causing weight losses between 12 to 20%. It won't change much. And you are going to be changing that sick fat that I mentioned into a healthy fat that will keep the fat in the subcutaneous tissue. I wish you lose it with lifestyle changes, but it's at least going to keep it away from the liver. So it has a pathophysiological rationale.
Dr. Sarin, does F3 or F4 fibrotic stage, does it with aggressive treatment downstage the fibrosis in similar manner?
Yes, certainly it does. We were party to many of the trials by Gilead and also the saraglitazar trials. And I think even simple weight loss without any drug, like putting an intragastric balloon, which we regularly put, also rather than a bariatric, I think weight loss regresses fat in a very large proportion, and in a small proportion also fibrosis. But let me tell you, F3, F4 biopsy sometimes is a sampling error. So if the patient has a reduction in his LSM liver stiffness values, it is good. One more point which everyone might like to know is LSM is substantially fallacious in assessing liver fibrosis in NAFLD. Let's say you have two patients of cirrhosis. Both have a portal pressure or fibrosis. Portal pressure, which is twice normal, that is 10. LSM in liver cirrhosis due to hepatitis B will be higher than in NAFLD. Why? In patients with fatty liver disease or NAFLD or MAFLD, there are intrasinusoidal connections. Between two sinusoids, the connections open up. This does not happen in hepatitis C, alcohol, or hepatitis B. So a patient may have stage 3 or 4 fibrosis, but his LSM may be just about 10. He may have varices, his LSM may be 12. So please remember, LSM may be fallacious. But for the same patient, a reduction from, let's say, 14 to 10 or 20 to 14 is good. But it may be fallacious, so it's always better to do a biopsy if possible, as several papers in hepatology and subsequently gut paper last year showed that LSM is fallaciously low in a large proportion of NAFLD patients.
Nitin, you've been silent, so no.
Yeah, just a point to the point that you made about prediabetes, and I think little literature more recently now divides prediabetes as isolated impaired fasting glucose as a separate disease entity and impaired glucose tolerance as a separate disease entity. And I think the intervention has very different roles. So IGT people probably would respond much better than isolated IFG. So I think it's getting more complicated there. But nevertheless, moving on to the questions, there are a lot of questions on therapy. And Professor Cusi, there's a question from Rucha Mehta, and she asks you whether is there any concern of using GLP-1 in people who've got a stigmata of CLD, chronic liver disease? You're on mute. Maybe I'll repeat the question.
Just to lie, and what disease? In cholestatic liver disease, you said?
No, chronic liver disease in CLD or cirrhosis. Yeah.
Well, first, there's not a lot of data, but there was a paper earlier this year, or late last year, with semaglutide in people with cirrhosis, with early stage with compensated cirrhosis, that in the liver field was taken as a negative study because it didn't improve steatohepatitis or fibrosis. It was a small study, 70 patients, but treated for 12 months. But I saw it as a very positive study from an endocrine perspective because they lost a significant amount of weight, those who were obese. A1C improved significantly into the normal range. And maybe a longer study would show, I think expecting reversal at that stage is unrealistic, but maybe you halt progression. And if you keep a person 2 or 3 years without decompensation, I mean, that's fantastic. So I wish that study, Dr. Sarin has so many patients, would do a long-term study. I can't believe that if you lose 5, 8, 10% of body weight over 3-4 years, that's not going to have an impact on the natural history of the disease. But for us, it's very important because Sanjay and I know that you cause a lot of hypoglycemia treating people with cirrhosis with insulin. So if you can use safely GLP-1s, I think it's a big step forward in the management. And again, I encourage the pathologist to talk with endocrinologists because there's a good way to monitor hypoglycemia with continuous glucose monitor. I know they could be expensive, but it will improve the quality of life of people with cirrhosis quite a bit. So I think it's encouraging to use GLP-1. I know there's also in that cirrhosis review that we published in Hepatology 2 months ago, we also talked there's emerging data with SGLT2 inhibitors, that you have water excess and hepatic renal syndrome. So it seemed to be helpful. But again, these are early stages.
Great. So there are a lot of questions on saroglitazar, if I may ask Professor Sarin. So would you use it in people without diabetes and just fatty liver disease? And what would be your experience with saroglitazar?
Yeah, we use it very often. Saroglitazar in F2, F3 fibrosis, sometimes in F4. We do not generally recommend it in cirrhosis, especially those who have dyslipidemia. Sara is a good drug. It decreases fat, sometimes insulin resistance, but I'm not too sure. In our study, we had 101 patients, and there was a reduction in fibrosis also. You need a 2-year, at least, long-term study to have the effect. So I think it's a good drug, but we need to add on other drugs onto it. Sara needs support. I have a question to all the endocrinologists, including Professor Ken Cusi. Whenever you are giving GLP-1, we are doing a few trials in that. It's written that this can cause pancreatic cancer or thyroid cancer, rarely. So the worry is that, is this something which should worry us? And the patients keep asking.
You're muted, Ken. You're muted.
Oh, sorry. Yeah, there's some background noise. They're cutting the grass here, and the typical thing. And we just don't have any dogs barking, but we're good. So my brief take is that there have been many meta-analyses and FDA, and I don't think they believe that there's an increase in pancreatic cancer, and I don't think there's an increase in medullary thyroid carcinoma as seen in some rodent models. So I think it's relatively safe. I saw a question that there can be a mild elevation in liver pancreatic enzyme, amylase or lipase, that is, we've observed in some studies, but it usually is asymptomatic. So perhaps the most important message for the audience is don't give it to anybody with a history of chronic or acute pancreatitis. What do you think, Sanjay?
Yeah, we generally don't give it because most of the incretins we would tend to avoid patients who've got, altered pancreatic lipases or amylases, because that's an absolute contraindication when we really think about incretins. And I'm sure Nitin would be doing the same. Yeah.
Yeah, and just a point for the medullary thyroid cancer, I think whatever has been shown in rodent models is probably because the C cell concentration in rodents is much, much higher than what is there in humans. And so that cannot be directly translated to human studies. So I don't think so. It's a matter of concern.
I think we'll have to close the conversation. We've exceeded the time, but the conversation has been so interesting and we keep getting more and more questions. It's lovely to have Dr. Sarin, Dr. Cusi, and Dr. Yagnik was icing on the top that we have all three stalwarts out here. Nitin and I would like to thank all of you for being part of this interesting discussion and bring out so many new aspects of MAFLD, MASLD, NAFLD, and I'm just losing count, and I hope we don't have new nomenclatures in the future. But thank you so much for a lovely evening and an interesting discussion. So thanks once again.
Thanks.
Thank you. Take care. See you soon.
Thank you. Good night.
Bye-bye.
Thanks. Bye-bye.